I want to take a minute and introduce, with great pleasure, our very first guest speaker, Jeanette Edwards. She, up until February of 2021, was the provincial lead of system integration and quality management and the interim provincial lead for Indigenous Health for Shared Health in Manitoba. Prior to this, she was the regional director of primary healthcare and chronic disease with the Winnipeg Regional Health Authority. She also worked with Manitoba Health in the capacity of special advisor to the Deputy Minister on Primary Care. Jeanette is semi-retired, but I mean, semi, I think, is really the word in that. She currently is a part-time surveyor with Accreditation Canada, and she's also on the board of Healthcare Excellence Canada, the board of the Rehabilitation Centre for Children, and the Manitoba Association for Seniors Communities. Jeanette remains engaged in areas of research, including the prevention of early childhood tooth decay, community rehabilitation models, and healthcare transitions. So, Jeanette, I'm going to turn the floor over to you. Kate, I just want to see if you're ready to share Jeanette's deck, though. Is that good if I stop sharing?
Yeah, let's do it.
Thank you. Okay.
And give me a second to get your deck up, Jeanette. How does that look to everybody?
Yep, I can see it.
Beauty. Take it away. Tell me when to change slides.
Thank you so much for that introduction. And Mandy, thank you so much for an excellent highlight. I do want to acknowledge that I work, live, and play on Treaty 1 territory. My spirit name is Grandmother of Four Feathers, which I hold dear to my heart. I should also tell you that I am right now in the far north of Alberta and delighted to know that my Wi-Fi was working. I am going to give you some highlights, and you're going to find some of these slides are quite dense in their information. So they will be provided with you for you, because I think it will give you additional context if you wish to then take a look at those. Next slide. So in this session, the goal is to really understand what is primary care and how is it different from and connected to other kinds of healthcare within our system. So there were some key questions I was asked to address. How healthy are Canadians, specifically here Manitobans? What do we mean by primary care? Why is it important? And why do we have a crisis in healthcare today? Next slide. So first, let's talk very briefly about the Manitoba population. So when we talk about life expectancy, that's really how long do we expect the average person to live? And then we also have very interesting data on premature mortality, where death occurs before the age of 75 per 1,000 residents. I think what's really important for us to understand is that low-income Manitobans, which are mostly found in rural, particularly northern and urban, but particularly northern and Winnipeg, are more likely to die prematurely than high-income Manitobans. Dr. Pat Martins, before she passed, led the Manitoba Centre for Health Policy. And I will never forget her analogy. She told us if you got on a bus in suburban Winnipeg and then got off the bus in downtown Winnipeg, you could expect to die 18 years earlier than people in suburban. And I think it was such a profound analogy. So I leave that with you to think about through your conversations, particularly related to equity and access. And this pyramid just shows you what our population looks like. So you can see that our population is aging. So the bubble is moving up, and it just shows you the projections. Next slide, please. So what are some key characteristics I think will be helpful for you to know as you are in your deliberations going forward? The highest growth rate we have in Manitoba are actually Winnipeg and the southern region. The birth rates are higher in some of our populations, and we also have a very diverse population with the highest number of newcomers in our province per capita than anywhere else in Canada. And that's a little known fact. So we've certainly got our highest population of Indigenous peoples, 18%, than any other province. And we have the highest number of newcomers arriving to the province. I think another important point to think about during your deliberations is that 44% of our population is in fact rural. So we need to remember our diversity. And I always like, when I am speaking to people, to distinguish what we mean by rural and remote. So we also have a very large population spread throughout vast geographic communities, particularly in our far north. Next slide, please. So as I said, these slides are very dense in terms of the material, so I'm not going to go through that all here with you now, but I did want you to have this information as you are looking at your conversations. A couple of key points, however. Over half of Manitobans over the age of 40 experience one or more chronic conditions. And this is a very important point when we talk about primary care. Another very important point is our prevalence, or the number of people with diabetes, is much higher in Manitoba than the Canadian average. And in some areas, like in the north, it's actually 2 times higher than the provincial average. So keep in mind as we move forward of the importance of chronic disease. And I did on this slide want to make one other point, and that is the point about poverty as a key contributor to social complexity. So often throughout my career, I think it's important for us to recognize that primary care is important. But around primary care, you may hear the language primary health care, where we need to work with all sorts of other sectors that impact on healthy communities. Next slide, please. So as I was reviewing and getting ready for this, I thought I would give you 2 quotes I thought were particularly relevant for your deliberations. For Canadians with chronic illness, the quality of the interaction with their family doctor makes a difference, not just in primary care, but in other settings. So it's very interesting when we look at surveys of Canadians and so on, that it's the quality of the interaction and the continuity of the interaction that makes the biggest impact in terms of the sense of well-being. So with the Commonwealth Fund International Health Policy Survey, the Canadian respondents with chronic conditions were more likely to relate their care as excellent if their regular doctor knew their history and helped coordinate care. And I'm just leaving that with you because I will go over what are the key components of primary care. Next slide. So what on earth do we mean by primary care? And the 50 years I worked in primary care, this is the constant question, and I'm sure Mandy can identify this with this. Generally, we find in Canada that this type of care typically involves routine care. Sometimes it involves care for urgent but minor or common health problems. It involves mental health care. So that is mental well-being, and emotional well-being is all part of primary care. Primary care includes maternity. We have many family physicians that continue to deliver babies as part of family care and ongoing child care. It includes psychosocial services, liaison with home care, health promotion, disease prevention, nutrition counseling, and end-of-life care. Sometimes you will hear the language from birth to grave. It is across the lifespan. And in my work in this area, particularly in the last several months, I talk about primary care as being relational-based care, not procedurally based care. And that's what makes it stand out and is different. The 2023 American Academy of Family Physicians, I lifted this from them as I thought it was very helpful preparing for your conversations. It's the provision of integrated and accessible health services. It is provided through teams who are accountable for addressing a large majority of personal health care needs. It's based on sustained partnerships with patients and practicing within the context of a patient's family and community. So it's team-based, it's community-aligned, and is designed to achieve better health, better care, and lower costs. Next slide, please. In Manitoba, and if you refer to the Manitoba Health site, this is the language used. Primary care is the foundation of the health system. And this is something I worked a great deal on in working in primary care in the province, and really pointing out that it is the first point of care to the system and needs to be seen as the anchor of the health system. You'll often see the term 4 C's, or key components of primary care, are as follows. The first contact, it's comprehensive care, it's coordinated care, and there's care continuity. And you will see the term called primary medical home. In Manitoba, it's sometimes called a primary care home. In other words, my family doctor is the one where I seek all of my care, who knows who I am and my history. I was curious to see last week some recent literature talking about, we really should be talking about 2 other C's of primary care. And I leave this with you because I do think it's very important. Cultural humility, another C, and convenience. So if you're going to be the first contact and comprehensive, how do you have convenient access? And should that be another C? These are essential components to radically improve the health of our population. And you can reflect on the data. So we need to deliver care that everybody deserves and expects, and create at the same time sustainable practice models for clinicians. You can't, as a single physician, meet all of these C's and be accessible 24 hours a day and so on. What does that mean? Next slide, please. So my question is, why or why not primary care? A report from the National Academies of Sciences of Engineering and Medicine suggests that primary care is the only healthcare component where an increased supply is associated with better population health and more equitable outcomes. And I really thought that was a profound statement if we're looking at what are we trying to achieve. And yet, knowing that, we still dramatically underinvest in robust primary care. And I've left you the quote here. There's some very interesting literature by Dr. Karg. So now my question is, can we afford not to enhance primary care? Next slide, please. I did want to give you a real quick overview of what has been happening in Manitoba. And I'm giving you this to really help you understand the amount of work that has gone on. And I'll close with questions for you to ponder. We have the strongest history in our province of community health centers in the country. And These have been in place since the 50s, where family physicians were funded through contracts rather than fee-for-service. We used to call that salaried. So a strong history of primary care alongside many other social services. In 2009, and this was some work a lot of us had done with Manitoba Health, we developed physician integrated networks. So it became very apparent that we could not rely solely on community health centers, which were strategically located in the province in high needs areas. We needed to reach out to the vast majority of family physicians who are in fee-for-service practice. So operating independently, although as Mandy pointed out, funded through a billing system for their services. And I've listed here the objectives of what we called PIN, but recognize that when I leave these objectives, we quickly had to do a lot of work in the background to engage all of the family physicians in the province. Next slide, please. The physician integrated network levered the development of electronic medical records in the vast majority of primary care clinics. So we proudly went ahead of acute care in this arena. Not everything is perfect, but we at least began seeing electronic medical records in family physician offices supporting their practice. We built into those records development to track chronic disease management and actually provide additional funding to fee-for-service physicians based on some quality targets, particularly in the area of chronic disease. That work developed into what is now today called My Health Teams, where we're now seeing groups of family physicians working together, even though they may have their separate practices. They now have the ability to hire a few additional staff that they share. And it's been very interesting to watch those become neighborhoods, so to speak, of primary care. And most of them have identified the biggest needs that they have and still have, are around chronic disease management and mental health. So the My Health teams are not about buildings. It's much less about physical space, but more about levering knowledge together. Some of those group practices, by developing partnerships, are able to provide more extended on-call. So one physician isn't on call all the time, but it's shared across a broader group, improving access. So I leave that with you so that you can see what has been occurring and actually in place in the province. Next slide, please. Embedded in the My Health teams has been support of home clinics. So if you go back to those C's, recognizing it's important to have coordination, it's important for a patient or a person to have a primary care home. These are very much supported in Manitoba, and there's been a lot of work going on through funding agreements and so on. You should also know in Manitoba that we have nurse practitioners. We also have physician assistants in some primary care offices. And these have really supported those My Health teams to expand their ability to take on more and more clients as a primary care home. A new fact that is all of a couple of months old is Manitoba now has a new funding agreement with the Medical Association. And I think what's really important for you to know is this now is a funding agreement that supports longitudinal family medicine. So it's not strictly volume-based care. So patients can go in with more than one problem, knowing that family physicians will now be funded based on comprehensive care and chronic disease management. So I think that's a very important ingredient for you to be aware of. Next couple of slides that I'm going to share with you, and you will get these, we can go to the next slide, please, are actually from the Manitoba Clinical and Preventive Services Plan. So Mandy pointed out that there's one provincial health authority. And one of the roles of that health authority is to engage all of the other authorities in developing a provincial system so that we have a common strategic plan across the province. So the important piece on this slide is the intent of that plan is to move towards a much more integrated workforce and a much more coordinated system of delivery of service. Next slide. Again, lots of information here, but I'm going to point out a couple of points on the in the future. These are all from the clinical services plan. So although it was completed in 2019, it is the foundational piece for all the planning going on now. Two key points here that plan is striving for is more consistent and reliable services so people know where to go for care. And I'll bring to your attention the last point on the right, that there will be primary care teams that support care closer to home. And that might be virtual, it might be through teams, but a very important point, particularly for our rural and remote communities. How do we make sure that primary care is accessible regardless of where you are in the province of Manitoba? Next slide. Again, lots of information, but the vision for the future in Manitoba, and again, I'm going to focus you on the right-hand side of this slide, is that your primary health care team has the information they need to provide comprehensive care. So what does that look like in terms of communication, in terms of sharing information on electronic records and so on? And the second point there is that each step in a person's care path needs to always connect with the local primary care team so that in order for primary care to be the coordination of comprehensive care, the rest of the system needs to connect to primary care. Next slide. Again, lots of information for you, and I'm not going to go through all this, but I thought you might find it helpful. But a couple of key points. That very first time, that 49 to 59% of emergency department visits are actually presenting with low acuity needs. And it was fascinating to me on the news last week that people were very concerned about their emergency department not being open 24 hours a day, 7 days a week, because that's where they were going for their primary care. So it begs the question of how much of the waiting room time in emergency rooms could in fact be managed with more support to primary care teams. And the second point on this slide is making sure that we're linking with primary care. Almost 1 in 3 Manitobans do not have a family physician or a primary care home or seek care regularly. And in fact, in many places, and the hotspot here for sure, is communities in rural and northern persistently are unable to access regular care, and certainly for primary care, very, very difficult. So my last slide, I'm watching time very carefully. Jasmine's given me my directions here. My last slide is primary care in Manitoba, what next? And so after just quickly reviewing this in a snapshot, I'll leave with you a couple of thoughts. It appears to me we have the ingredients. We've talked about the funding model, electronic medical records, focus on chronic disease. We've talked about all sorts of things, but what is missing? We have a plan. We deliberately have the Manitoba plan, which was so focused on primary care. What is missing, or how do we actually get to the step of implementing? And I leave that with you because It's a bit like baking a cake, and we have all the ingredients out and we have the recipe and the plan. But what does it take to pull all of that together? And my last worry point as I age is we need to make sure that primary care doesn't become another silo in the system. We need to build primary care, but it must be within a system context. I'm going to give you a real live example. My mother, who is very old and very frail, whenever she goes into hospital, I shudder. It takes me more time getting her back out than you could imagine. And every single admission, whether it's tertiary care or a community hospital, nobody contacts the family physician, even though I make sure at the point of admission that they've got the name, the cell number, everything. And it still is a system that people seem to think a discharge summary is good enough rather than discharge planning together or talking to the primary care home, which I'll go back to my earlier comment. This is the foundation of the health system. So that's my passion and my few points. And Mandy, chime in, feel free.
It can be very hard, when they discharge patients from the hospital, and often what they say is go see your family doctor. They don't give patients a lot of information about what they're supposed to see us for post-discharge, and then they don't always send us the information, and then you spend a lot of time on that visit trying to figure out what is needed to be done, instead of actually doing what needs to be done. So it can be very frustrating, and it really impacts patient care and their experience.